Hi, we're one of the teams from the University of Alberta Hospital CICU, and we are going to be modeling and simulating how to intubate a patient that is either COVID-19 positive or potentially COVID-19 positive. As a first step, you can see that absolutely everyone in the room is fully gowned with proper donning and donning technique. I will refer to previous videos that have donning for more reference on that. And we're all wearing N95s along with a face shield, but due to not wanting to burn precious personal protective equipment, we've just put the sticker on in front to signify that we're wearing N95s. The room is also closed, and we've tried to minimize the number of people in the room. So for the first step in intubating a COVID-positive patient, we suggest going through your own unit's intubation checklist, which serves as a timeout just prior to intubating. So we're going to be intubating this patient that likely has COVID-19. I'm going to go over first the drugs that we need to have in the room, and they should already be in the room so that we minimize the number of times that people go into and out of the room. So for drugs, do we have ketamine, 100 milligrams, propofol, 100 milligrams, fentanyl, 100 micrograms, midazolam, 5 milligrams, rocuronium, 100 milligrams, phenylephrine, 1,000 micrograms pre-filled, and norepinephrine ready for use. So the second step is to ensure that the patient is optimized by the checklist. I've already completed the airway exam. There are no difficult airway characteristics, but if there were, we would consider getting anesthesia involved. And specifically for COVID-19 patients, we should always have the most skilled operator do the first attempt. The positioning is optimized. The patient is being pre-oxygenated currently on 15 liters via high-flow cannula, and we'll be putting the 15-liter bag valve mask on top with a seal with no bagging to ensure pre-oxygenation. The patient is already on pre-intubation fluid bolus as well as vasopressors. This patient does not need a pre-intubation NG because he has not eaten recently, and we have 2 IVs that are in place. So the next step is in the checklist is to look to make sure that our airway equipment is ready. So number 1, do we have an endotracheal tube with cuff checked, and we have a 6 millimeter backup tube? Perfect. We have a bag valve max with oxygen, PEEP valve, and continuous end-tidal CO2. Do we have an OPA, an NPA, and we have suction available and working. And in this case, we'll be using glidoscope for primary intubation, and we have a direct laryngoscope available as a secondary option. We have the high-risk airway part along with LMA outside if we have a failed airway. So the next step is to ensure that we have all our monitoring equipment ready. The first is to have NIBP cycling every minute, as well as on the arm. We have a pulse ox on the opposite arm, and we have end-tidal CO2 continuous waveform. So the last step in the checklist is to ensure that everyone on the team knows the plan. So we're going to be intubating this COVID-19 patient who has a low saturation. We'll be using glidoscope as our primary technique for intubating with rapid sequence induction. If this fails, my plan is to go to direct laryngoscopy, and if that fails, we'll put an LMA in and try and get a more experienced operator in the room. Any questions, concerns, or is everyone ready to go? So now that we've gone through our checklist and the patient is prepared, we'll continue with intubating. As you can see, the patient is on 15 liters via high-flow nasal cannula. And we've also put the bag valve mask on top with flushed oxygen, but we're not bagging so that we do not aerosolize anything into the environment. We will then proceed with rapid sequence induction for this patient. Typical doses that you may use will be starting off with between 25 and 100 micrograms of fentanyl, between 1 and 5 milligrams of midazolam, approximately 1 milligram per kilogram of propofol, so in this case we'll use 100 milligrams of propofol, followed by 1 milligram per kilogram of rocuronium. In this case we'll use 100 milligrams of rocuronium for paralysis, and we will wait 60 seconds for optimal intubating conditions. So after 60 seconds have elapsed, we will proceed with intubating the patient. The first thing we'll do, just so that we don't have pressure buildup underneath the mask, is we'll stop the oxygen in the nasal prongs. And after that, we'll take the bag valve mask off, and I will proceed with intubating. what we're going to do is we're going to go straight onto the vent. When we're done, you can take the stylet out, please. Thank you. And again, we have not bagged. We're going to put the cuff up, and we're not going to go onto the bagger. We're going to go straight onto the ventilator, and there's end-tidal CO2 hooked up on the ventilator. And then we're going to turn the ventilator on. This minimizes the number of disconnections in the circuit. And then the patient will have been intubated. After you've successfully intubated the patient, ensure that you've secured the tube. It is very important that as healthcare providers leave the room, that they appropriately doff, which is the #1 time when healthcare workers get contaminated. And we also do suggest that while you're in the room once, you should probably put the central lines and heart lines in during this time rather than leaving the room and coming back in. So it is ideal to have all that equipment ready to go prior to intubation. Thank you for watching our video.